started work a little bit late, and I used to exercise in the morning and go to work around 10:30, 11. But I finish work at 11 o'clock. I start my clinic at 7 o'clock, and then it goes on till 10:30, 11. And then I come home late. And suddenly I discovered, as soon as we shut down, I think after the shutdown, we shut down the work as well. There were a number of patients in the hospital that we had to look after, but I personally took the time off, and it was unbelievable that I slept almost 10 to 12 hours every day for the first week. I couldn't believe. I thought my body required rest, and it was unbelievable that I was able to actually capitalize on that. I didn't get bored. Discussions that were taking place, and we can talk on what we did and how we tried, and also tried to restart the program. There's an interesting aspect to that, because we failed in trying to restart the program because there were many surprises. In fact, for me, it was a very, very restful period, and I almost thought it was a blessing in disguise. But now we are entering a phase when really there is no end to it, or looking for this to go on for another, maybe another 4 months, 5 months till the end of the year. We don't even know what will happen in the winter days and in the rainy days, when things are going to get worse or not. There is a huge unpredictability, and you were talking about the financial implications of that unpredictability, and how we can actually safely perform the routine work. Because I believe that the routine work is suffering. People are afraid of coming into hospitals. Really, of undiagnosed cancers is going to have a huge implications on cancer patients who may be presenting late to us when all of this is over. Many transplant patients have had no opportunity of life because there's been no organ. I noto for the last 4 months. There has been some periodical organ donation happening here and there. So patients with end-stage liver disease are dying. We are seeing a huge impact on the public, a huge impact on hospital. I will talk about it because one of the comments that was made to us was, be a COVID treating hospital, don't become a COVID producing hospital. So even authorities felt that the doctors could potentially do harm to the community. We can take up one by one and talk about it.
Suddenly lost the image.
Yeah. Yes,
Okay.
sir. Can you
been able to listen to me? Yeah.
Yes, yes.
Yeah. We can start one by one, really, and
So,
people can start asking, and we can have discussions.
Yeah, Biswarup, if you can take it from there as to how did your life change? Did it change for good or bad, or from bad to good and then to bad?
yeah, so first of all, good evening to all, and my respected Professor Rela and my friend Ilango. And Patta, thank you for arranging this. Now, to answer your question, I think first 1 month, my hospital, one block became second stage COVID center. So elective work totally officially stopped. And that COVID center ICU was part of my responsibility. The first 7 days, I have to say that totally in that 3 weeks when government was sending patients, or we were entitled to treat COVID patients, I used to go out of home with anxiety. And evening when I used to come back, I used to be even more worried, not knowing what I'm bringing home. And I also saw the changes in my apartment block, how people were avoiding traveling with me in this lift whenever I was climbing up or down. My own anxiety while treating those patients, totally we came across, we had admitted probably 118 patients, of which 38 turned out to be positive. And I think progressively we as human beings get used to anxiety. Then it becomes part of the habit. And after some time, I didn't remember also I'm in COVID ICU, apart from certain protections which we all were taking. And the second thing I had to get used to, is that traditionally, wherever we have trained from first year MBBS or got taught, go close to the patient, examine the patient history and all that. Today, suddenly, after so many years, I am telling my younger colleagues and I am telling myself to distance from the patient. Now, this is a paradigm to which all of us have to get used to. Whether our patients will get used to, I'm still studying. It is the thought or understanding in evolution for me. That is how my clinical life has shaped. What do you think? I'll ask Prof. Ilango and Dr. Patta as to what has been your experience going towards patient or treating patients.
No, actually, we'll dilute the conversation, Biswarup.
Okay.
We have prime time with Dr.Rela and you, and we actually Dr.Rela being a role model to many surgeons. They just want to know what is he up to, what is he thinking, and what is the future, and so on, because he thinks much ahead of anybody else. So we are just wondering.
I'm just giving a personal opinion. See, when the whole thing started, I felt that India was going to be in a relatively better position. I did a TV interview and I wanted to be positive. I felt very positive about it. The first reason I felt positive about the whole thing was that China controlled it. If China can control it, I think if we worked hard enough, we should be able to control it. Gradually, that confidence was eroded by what happened in Italy and Spain and the UK, and now the United States. I think, I don't want to criticize the government. I think our government has done well. Many people are saying now, we had a lockdown when we had 200 cases, and the lockdown is going to be lifted when we've got 20,000 cases, which is true. I think from this point, things can only get worse. I believe that India would probably be, I don't know whether we will record them officially, India would probably be the country with the largest number of COVID-19 patients. I think that is going to be the case. And that might happen in about 2 months' time. So we all have to be prepared for it, and we all have to work differently. People say we have to learn to live with it. I don't think it's the right way to look at it, because nobody is going to be able to live with it, because it comes with disasters attached to it. There are many strange things. We actually wrote a letter, which is an article which is going to be published. We started writing it when we were thinking that India is going to escape, because they said the weather is in favor. They said the strain is maybe not such a virulent strain in India. We are not seeing the ICU mortalities as much as the Americans or the Italians, because we can't be hiding the COVID cases, because if we are hiding the COVID diagnosis, the hospital beds are going to be inundated with patients, and that is not happening. Maybe, I don't know. I think Biswarup may have an idea. We started admitting COVID patients only about 2 weeks ago. And if we are not careful, we are going to be inundated with cases. We have about 35 patients in our wards. About 5 patients are ventilated. We have about 7 patients in intensive care. But I have to say, this is an early experience for us, and patients are not doing so badly. Even though they come in, get ventilated, and go on 90% oxygen, they seem to be, my understanding from our intensivists, they seem to be getting better. We don't have the cytokine storm as described by the Italians. But I find it very difficult to think that the mortality rate in Chenna is about 0.5 or 0.6%. In the same country, the mortality in Gujarat is around 4%, and the mortality in Maharashtra is around 3.5%. I mean, why should we be so different? That is a question that if any of you are there, you can answer. There are articles coming in, I think there is one in Independent which says that not Tamil Nadu government, some other Indian government is saying not to put COVID in the death certificate. They have officially actually issued instructions not to put COVID in the death certificate. So these are all quite worrying, and therefore it's going to take time for us to really find out the true extent of what we are going to face.
Yeah, I mean, I think my experience with COVID is similar to what Prof described. And in between when
do you completely agree with Professor Rela when he says that our death rate in Chenna is much lower than the rest? You agree?
Yeah,
You think the figures are true?
I'll make a very open statement because in Telangana, I'm part of the core committee of the state. The only thing I can say, this is a closed forum, only consistency we have about government policies or directives is inconsistency. I think through that, I can express that the number is possibly wrong by 50 to 100% or even more. Because we have not been allowed to test posthumously till 7 days ago. Only 7 days ago, we got another directive that in suspected cases, we can test posthumously. So a very big number of cases which are dying are not. So in my mind, actually, for every, sorry, hello?
Yeah, can you?
In my mind, for every positive case that is officially announced, I am actually having another 10 cases detected but not officially announced, and another.
This is pan India or Telangana?
I think the government activities and nature is same everywhere. I think so, because I am familiar with what's happening in Gujarat and Maharashtra. By talking to, I was in Gujarat only till 1.5 years ago. So that is how. But sorry, I didn't finish the sequence. So for every 1 positive, 10 positives are not declared, and at least another 30 to 40 are not tested, because testing policy is continuously changing, subject to various intentions. So that is as far as the denominator. As far as the numerator, case fatality rate, only the patient where positive report is there, that death is COVID positive. The ones which are not positive report but COVID-like are not coming into the numerator, which is making the case fatality rate relatively less in various locations. This is what my conclusion. So the overall spread, I am looking at least 15 to 20 times more than what we are seeing. And I'm expecting by December, 50% of Indian population will be COVID positive. And for all you know, I might have in last 2 months, 3 months have become positive and negative. I don't even know.
But that's the good news that, you're quite, normal.
Pragmatic.
So it's like very likely that we all continue to be normal, contrary to the statistics you're commenting. Effectively, see, the scare is very much there. Everybody's got a little sore throat, a little feverishness. They're scared. They're thinking of the Damocles sword. Right now, Dr. Rela was suggesting that we have to live differently, or learn to live differently. How to learn to live differently as a clinician. Now, going to the OPD, we don't want to see patients. We don't want to touch them. We don't want to talk to them. We are scared. And then, there is some sort of a disconnect has come in there. Surgery, we are also, our decision making is totally changed. No guidelines are fitting in. For any emergency, we push a little more and see whether it can be, managed. I mean, I would like to ask Dr. Rela to start with as to how should we be different as a clinician.
Okay. Now we were operating until the end of March. We had a busy month. We had the MCLD as well, end of February, and we had some people coming from Italy, and I really think we were extremely lucky that we didn't bring COVID into this country through a meeting I'm not even sure if actually there are patients who became asymptomatic and got better at that time. So really at the end of March is where the shutdown was. And we were told that we could do acute liver failure or emergency cases. What happened, we actually shut down for 2 weeks because, there was a kind of a fear with everybody, and unless it was an emergency, we didn't do any operating. We canceled all the outpatient clinics because outpatient clinics was one of the areas where we thought we could be getting COVID into the hospital. And at that time, there were no real PPEs available and, the N95 masks, and none of that was actually in ready-made or in ready supply for anybody for us at that time. So let's say there was a period of fear among doctors, among nurses, and everything was shut down for a period of 2 weeks. But then we felt that we had to get started. It was 3 weeks of no work, and one we needs to pay salaries. We talk about how to deal with the financial aspects of this. And then we started. We did 5 cases. And then 6th case happened to be an acute liver failure, a Wilson's child, in fact, funded by the government, a completely asymptomatic mother, and she tested positive. We didn't know what to do, and she met, I think, almost 40 or 50 staff within the hospital, because the transplant workup involves so many people, the surgeons, the ENT people, the dental people, it's the cardiologist, the respiratory physician, the psychiatrist, the whole lot, about 40 to 50 people, the CT scan, the radiologist, the radiographer. And really, suddenly we had a situation where we had to have almost about 70 to 80 people who have been in contact with a person who's been totally asymptomatic and remained asymptomatic. Now, we were really, the government got very excited because the first response of the government is, oh, the patient's been in hospital. So one of the staff has given it to the hospital, to the patient. That was the first response. And I mean, nobody really spoke to me directly, but I had indirectly people indicating to me that they may want to shut the hospital down because there were many, many small hospitals which were shut down when they identified a case. I think that is not the case now. I think they have changed the policies. And another thing happened at a very similar time. We had 2 patients in the ward with decompensated chronic liver disease. And they've been in hospital in and out for, they came in for tapping and then they were out of the hospital. And suddenly they got a respiratory illness and we got a chest CT and the findings were classical of COVID. And both of them were positive. Patients were admitted with chronic liver disease. Now we had 3 patients. And then one of the patient's wife became positive. Now we had 4 patients. So we suddenly became a hotspot. Now our case was handed over. The government said they couldn't deal with it, and they handed it over to ICMR and said, you investigate the contact tracing. Now with 3 patients involved and 1 more relative involved, there were almost about 200 people were involved as contact. So the government said all of them have to be tested. The officials said you're a COVID producing hospital, not a COVID treating hospital, because we hadn't started treating anybody by then. So what was amazing was the 200 tests that were done by ICMR, not 1 person was positive. So this actually gave me the confidence that it is not such a big problem. I mean, how can you have 2 patients in the hospital for 2 weeks with a nurse turning the patients, examining the patients, feeding the patients, and none of them. And I have to say, I have to give credit to the nurses because we have very strict policies even in a normal ICU, because the nurses have to wear apron, they have to wear gloves to touch the patient, they have to wear a cap and they have to wear a mask. And it seemed that normal septic precautions in an ICU, in fact, protected all of these nurses. So we have not, so far, we've been running now for 6 weeks, I think. We have not had any staff who have tested positive so far, except one translator recently who's tested positive now from the community, I guess, from outside. So that gave me a huge amount of confidence. And this whole process actually took almost a month, really, for them to complete and give a report. And after that, we really restarted. And this time we restarted, we had testing facilities as well. Our testing facilities came because we were a new hospital and we didn't have NABL. So, but it's a month now, we've had testing facilities. And we were designated a COVID hospital, and we started 2 weeks ago admitting patients, and now we have about 35 patients. We have a separate entrance and we have a separate floor we have allocated. So there is no communication from between our main hospital and the COVID hospital. And there is no mix of staff, and everything is separate. And also in the last 3 weeks, we have done 11 liver transplants, living donor liver transplants. We have had no problem so far. But the 12th donor, once again, the 12th donor has tested positive during the workup. Now we do the workup before starting any other workup. So they're not going to be meeting many people, and then finally we do the testing. Now for the transplant, we have a policy that the patients will be tested, and this is for all major surgery. They will have an outpatient testing done. And if they are found to be negative, this is for hepatectomies, transplants, and donor hepatectomy. And if they are negative, then they come into the hospital campus. We have accommodations, we have a hotel inside, and they will stay there for 4 days, and then they will have a second test done. And the 2 tests done probably will reduce the negativity of the test, false negativity probably by another 20%. So you can have a more than 90% false negative rate if you do 2 tests at 4 days interval. And in that 4 days, we expect the patients to stay in the hospital campus and not go back into the community. And then we bring them into hospital and do the operation or do the transplant. So the 11 cases we have done in the last 2 weeks have done very well. We have had no positive patients in the post-operative period. But we have recently had one patient whose chest X-ray looks like COVID. This is not a transplant patient, this is a hepatectomy patient. But the patient is clinically very well, but the test for COVID has been negative. So we practically manage this patient as really COVID. We can after some time, Biswarup, we can talk about the cost of treating these patients. Yes. I mean, there are videos floating around saying in South India, they're
yesterday
cash secure. We can talk about all of that and how insurance companies behave.
Yes. So,
Biswarup, what we could hear from Professor Rela is very heartwarming that, it's not that contagious. But Dr. Rela, and possibly you also work in an environment of transplant where, you cover yourself, protect yourself very well, but others like us don't. So can we extrapolate the same, lack of fear to the others as well?
No, I think as professionals, Biswarup was talking to me earlier on. We are brave, actually. I don't think in this world, there have been many, many infectious diseases, and the medical profession has actually got into it, really. I mean, if you look at many people who discovered and worked in these, with these infectious diseases, many of them have actually died, really. People who worked on vaccines, even, Mary Curie, who discovered X-rays, died of really complications of radiation. So the medical profession has always been very brave in dealing with things, and but we need to be careful. I don't think we can really take it easy, and it's very important that the older people like us maybe are more vulnerable than the younger people. So maybe it's quite right for the younger people to be in the front line rather than the older with comorbidities, which is really the opposite of, when HIV started, when HIV was a problem and we were operating on HIV patients, I used to work for a boss, a consultant surgeon in Liverpool, who will never allow juniors to operate on HIV patients. He'd always say it has to be done by the older people who have secured their life and who've got their children, and it doesn't matter for the older and the more senior surgeons to operate on HIV patients. So maybe there is a reverse component here, because younger have a milder illness than older. But how we operate, I've just told you that we do 2 COVID tests before we start operating on patients. But while we are operating, we treat everybody as COVID positive. All the precautions taken during the operations are as though the patient is COVID positive, and all the precautions taken in ICU are as though the patient is COVID positive, even though they have tested negative twice. So that's the principle we currently follow in order to protect the patients and the doctors and the nurses. I don't know how long we can do that.
There's a feeling that we are overdoing, sir, in that area, trying to treat every patient as COVID. And for how long will it go on like this?
See, I think this whole thing could settle down in 4 months or 5 months. The worst is yet to come. The problem of having patients becoming positive while in hospital is real. And when patients become positive while in hospital, because there is only a 70% accuracy for these tests, when they become positive, that means potentially 1/3 or 1/10 of your patients going to be positive. And that means when these patients are really handled by the doctors and nurses, they will have to go on a quarantine. So you are risking large proportion, for one patient, you're risking large proportion of patients to be taken off the duty. So if you want your staff to continue to work, you will have to follow these. Otherwise, periodically, you're going to get a patient who will become positive post-operatively, and then you will have to look at who are all been in contact. And because for 5-6 days, you're not going to know if they're going to contract the disease. And that is the only way we can actually protect the patients who come into our system. And we have to remember, this needs to be really further clarified. The reports have been that if a patient tests positive perioperatively, the mortality is almost 20% for the patient. So if you have that in mind, how can we not treat everybody as COVID? It's not for protecting us, it's protecting other patients who are there in the hospital.
I think a couple of things. First of all, I'm very grateful. Prof mentioned that example of HIV. Generally, we start from apprehension to fear. In COVID, what I'm seeing is we started with fear. Now we have apprehension because we are beginning to work. First 1 month we sat idle, except compelling situations, and then good habits will become culture. It is, we all as medical professionals anywhere have entered a completely new risk zone where science also is grossly incomplete. So precaution is the only option. Now at the same time, like in business parlance, we say there should not be analysis paralysis. Similarly, there should not be precaution paralysis. Otherwise, we stop running our business also, because then the building does not survive. That is how I would look at it. But I would take into account now that Prof has discussed so much about transplant. And I have attended I don't remember, it was April or sometime when LTSI webinar happened regarding guidelines for transplant. I can't remember, Prof was there in that. And incidentally, India, I'm not going into Noto-Soto dynamics, but India, though it's a country, but each state is conducting itself as in such matters conduct themselves in another country. Say, for example, in some states, there is moratorium on cadaver donation. And just to give you an idea of what has happened, generally India does about 2,500 cornea transplants, which means per month, which means 2,500 people get back their vision. I'm not even going into liver, heart, kidney, these are bigger things. And in last 3 months, as per EBAI, that is Eye Bank Association of India, there have been only 2 donations, 2 cornea transplants. And this whole precaution paralysis by government, or in general, overall, has led to at least 8,000 people not getting their vision back. And this one example should tell us that in the middle of all this pandemic, we still have to look after. Because the other thing is, I'm seeing that patients with acute problem, at least where I work, where normally they would have come to hospital within 24 hours, they are reaching on third day, fourth day in a much more advanced stage with acute abdomens or strokes. So there is a fear component with the patients that hospitals are a storehouse, as Prof said that, blaming that it's a COVID producing hospital, not COVID treating hospital. And that stigma is affecting the patient's mind. So coming back to transplant, my question to Prof is, do you think there can be some universality or uniformity across the country? Because I saw in the huge number of Maharashtra, Pune region conducted free donations. And in another state, there is moratorium. So maybe there can be some synergy and uniformity across the country. After this, we'll switch on to other topics.
Before Prof replies that, Dr. Amaravani, what is your question? You've been waiting for a while with a raised hand. And you should point your question to one of the two panelists. Dr. Amaravani, are you there?
Can you listen to me?
Yeah.
Good evening, sir. Mohamed Rela. Thank you very much for being on the panel. I just wanted to ask you, in the COVID era, is there any special consent? Are you taking any special consent that the patient might get infection from the hospital or from the healthcare workers?
Yes, we are actually. We are taking consent for all the procedures also, not just for the operation, that in the post-operative period, they could get COVID positive. We inform them.
And are you getting any COVID test done for your healthcare workers?
Yeah, that's an interesting question. Somebody else asked that question. I was going to start there. I think we'll discuss that. I think that's an important, because patients will ask that question. See, one of the things that I said earlier was, we conducted tests on about 200 of the staff, liver staff who were involved, and all of them have been negative. Now, if you want to do tests on the staff, I mean, we have 1,000 employees in the hospital. You will have to do it every week. There is no point doing it once a month. So we have done it a month ago. And what do we do now? Do we start doing all of it every week? And the cost implications are huge, which is exactly what I'm saying. So for medical legal purposes and for protecting other patients, I think it is important to do patients. In fact, we also do the test we only allow one relative and do the test for that single relative who stays with the patient. And no other attendants are allowed to visit the patient. There is only one attendant. So if anybody else actually wants to stay, they may also have to do the COVID test to come in. But if all of you are protecting yourself and considering every patient inside the hospital as though they were a COVID patient. But I have to say, the COVID unit PPE is not the same as the non-COVID unit PPE. So in the non-COVID unit, the protection is not really as much as Biswarup would tell. The COVID unit PPE is quite heavy, really. Therefore, no nurse is on call for more than 6 hours, because once they put it on, they can't eat, they can't go to the toilet. So they have to be there, and then 6 hours later, and they're doing an extremely good job of that. So we have to have 4 shifts for the COVID unit. But for the non-COVID unit, we don't have. But we tell that at every step, the doctors and the nurses have to be protected, so they're not passing on the infection and they are not acquiring the infection. So even if somebody becomes positive, whether it is in the doctor side or on the patient side, it's not necessary to isolate a whole lot of people. That happened to us in the first experience that we had. So the answer to your question is, we are not testing all of our doctors and nurses on a regular basis, because once you get into that, then you will be forced to test them every week, because it doesn't make sense to test once in a while and then they're back in the community and you're not testing. So we only test the staff. They have to enter, I think they have to enter a pro forma every week about their health conditions. And if anybody is symptomatic, even to the slightest extent, then they are isolated and tests are done. And it is not done routinely for the doctors and nurses, but it is done routinely for every patient and relatives who walks into the hospital.
Any use of getting the antibody levels done for the COVID staff, sir?
No, there is no available antibody test that is in clinical use yet in our part of the world. Tell me if there is, because I would love to have antibody tests done. Because as soon as we have the antibody tests, we know, as Biswarup said, so many of us may already be testing positive, and we can freely actually leave them to look after. I'm not even sure if that is a true statement. We'll come to that a bit later. When somebody is infected with COVID, how long they may be clinically recovered from it and even test negative on PCR, but we don't know how long they harbor the virus and whether it can actually reactivate if they are immunosuppressed or if they get illnesses. We do not have any idea of any of this. But I would hope that if they demonstrate IgG antibodies, they could be the people who can be the frontline staff looking after the patient. So it will be extremely useful to have the antibody tests. And if we have it, that might change the situation quite a lot for us.
Ilango, what's your comment or question? You have to unmute. Yeah, Ilango, you have to unmute.
Prof, good evening. Good evening, Biswarup sir. So my question is that, so I have put it up. We are one of the countries with the lowest GDP, and we have struggled for the last 3 decades to bring specialties like transplant. Now, with the current scenario, do you feel that our focus is going to change back on infectious diseases rather than major surgeries like pediatric cardiac surgery and transplants? Is our country going to change its health spending towards infectious diseases again? Do you feel like that after the COVID era?
I don't think so. I think we are moving on as a country where we are offering high-end treatment for almost all diseases. To be able to offer the high-end treatment for all diseases is exactly what is going to give us the instrument to manage infectious diseases in the modern world. So if you don't have the microbiology and the virology at a level, I always say this, when you have a hospital doing transplantation, they'll have a strong virology department, you'll be able to do CMV serology, this, that. If we don't move on with medicine, we will not be able to manage in the modern world infectious diseases either. So it would be a wrong step. Maybe the funding for infectious diseases. I think we have forgotten about infectious diseases. That's probably one of the problems for us. I mean, how many of us knew in our medical school, maybe it was there in our medical textbook, about the death rate of the flu pandemic in 1918? I believe that almost 8 crore people died in India. I did not know until this happened that the flu pandemic killed so many people at that time. So I think it's important that we invest in the infectious diseases and be ready to control them just like any other part of the world, because nowadays, no disease is going to be, it's not like, malaria, where it's going to be endemic in small parts of the world and we have to be fighting it on our own. These diseases are actually pandemic, really, not just in one area. It's going to be throughout the world. And maybe there needs to be cooperation. I mean, it's America going in the opposite direction, taking off funding for WHO. It's what's important is actually strengthen international organizations to deal with infectious diseases, so we can actually stop them from spreading rather than really deviate money from high-end medicine. I do not think we can afford to do that. That will be a retrograde step and people will start going out for coronary artery bypass grafts. We can't become so bad in this country. Actually, I have a gentleman I can see a picture of. There's a Dr. Reddy. I think he's just joined in. I don't know any of you know him. He is an anesthetist in New York. Can we make him say something? Because
yeah, sure. But you can unmute and come in, sir.
He's
Yeah.
a doctor, yeah.
Oh,
So-
Jay.
Hi, everybody. Hi, Rela.
Hi.
Can you hear me? Yeah. So, just to introduce myself, I'm in working anesthesiologist in NYU University, New York University Hospital. For the past 1.5 months, I've been taking care of only the COVID positive patients. 100% of my time was involved in taking care of these COVID patients. And right now, we have about the volume of the COVID patients reduced by 60%, 60%. So we have still having about 30% of the patients in the NYU University Hospital still in ICU. So at one point we had almost 250 patients we were taking care of. And right now it's, I was taking care of this patient when it's epidemic in, epicenter of the world actually. Now that we are out of our thing and we opened up, lockdown has been lifted. Now, only thing is, like I can tell you, is that we started working on a regular basis. So we started checking each and every day. We check when you're entering the hospital. We check the temperature and asymptomatic. Otherwise, we can't enter the hospital. So basically, we all got tested for the testing. When you're negative, then only we can enter the hospital. So as we're talking about, I'm more worried about now that the lockdown has been lifted in India. I'm afraid that it's going to be epicenter of the world. I think. I guess it's going to be like that. Unless otherwise you take good precautions, it's going to be like an epicenter for the corona, I think. So you've been taking good care of this. You've been taking care of these patients as if they're positive. That's the only thing which has been saving the hospital, I guess. That's even if they're negative, if they're positive, you're taking care of this patient with the ICU, everybody is taking care of. They're wearing all the isolation gown, mask, everything, as if you're treating them as if they're positive. That's the only thing which has saved the spread of the disease in your hospital, I believe. So going forward, I think one thing which can save in the future is getting the vaccine invented fast and then have all these patients like vaccine, like we are giving influenza vaccine, I think. So that's the only thing is going to be controlling this situation. Until that time, we are still, I agree with Rela that it's going to be like epicenter in India now when the lockdown is lifted, and then it's going to be there for until the end of this year, I believe, maybe 3 to 4 months to control the disease. That's my thing.
Can I put that question to you from before? You said
Yes.
temperature is being taken. I think we've been following that for the last 3 months. I think there is somebody taking the temperature at the entrance. But have your doctors been tested for COVID for coming into the hospital, or there has not been testing for the doctors?
Each and every person in the hospital, working in the hospital, is being tested.
How often?
Yeah, everybody is tested, and then if they're found positive, they're being quarantined for 14 days before they come to.
Then how often would you test?
We tested once, and then after that is negative. They test the temperature and symptoms only in the next hour.
But that doesn't make sense now.
Exactly.
That doesn't make sense.
I know,
Yeah.
but this is like this. We had to think about the practicality. So you can't be like testing every
Then
week.
why test? Because 1 week later, the validity of the test is not there anymore.
Then they go by the symptoms. That's all it is.
Okay.
Yeah, I think in conclusion, I think people who are having constant exposure, repeated tests doesn't matter. And before I switch over to another area, I think I'll just conclude what Prof was saying regarding this advanced or tertiary or quaternary care and infectious disease. I think I will summarize it in this way. It doesn't make more wealth by taking wealth from rich and distributing to poor. To increase wealth, one has to increase wealth, actually, in absolute terms. So we cannot attend to infectious disease at the cost of advanced medical care like transplant. That has to go on with additional stress or additional attention to infectious disease. That is how I would conclude that.
And ask Baskaran to come in for a minute. Baskaran, you have any comment in this area?
I would like to ask Dr. Rela two questions. One to the surgeon Rela, the other is the entrepreneur Rela.
So entrepreneur business will come later. There's so many questions there. As a surgeon, as a clinician, Rela, I should ask.
See the guidelines for starting surgery. See, it is necessary because of COVID lockdown. It is estimated that nearly 50,000 cases every month are getting postponed. Eventually, you are going to have a situation where you have about 3 lakhs patients coming in quickly as soon as it is deemed to be reasonably safe for patients to come in. Why don't we start opening up hospitals? Of course, you are doing a major transplant patients because they are required to undergo the operation. They cannot wait. But how about patients? See, the guidelines are inadequate as of now. So somebody who has had cholecystitis once or before he comes for the second episode, should he be offered surgery? And not every hospital may have the facility to do the COVID testing or may not have the kind of PPE which is required to operate on the presumption that everybody is COVID positive. So what advice would you give to lots of surgeons who are in small places, peripheries? They're all taking enormous amount of risk and operating.
Yeah, but this is what is risk taking. I believe that you have to restart the work. I do not think we can postpone surgery any longer, particularly cancer surgery or interval cholecystectomies and your appendicectomies. I don't think work has to restart. But how much of a risk do you take and how much of a precaution you take is where we need really very clear guidelines. Whether you want to take, because we are a much larger hospital, we have a combination of patients, and the stakes are very high for us because patients are immunosuppressed. So we have a policy, a very strict policy, that everybody is treated like a COVID patient, even when they have tested negative, and then we carry on with the work. I don't think that sort of a rule can be universal, and it's going to be it's not going to be very cost effective, and it's going to be expensive. We need to find a balance, and I think a standard operating procedures is very reasonable. I think Biswarup can talk about, they take some specific precautions during the anesthetic techniques. They do that through a little chamber, and they wait for 15 minutes because they say there is an aerosol and the whole thing settles for 15 minutes, and then only allow the surgeons and other staff to enter. So there are many precautions like that currently available for patients, even when they are tested negative, because this is particularly so for endoscopy procedures and the start of anesthesia. Our people are very particular about doing all of these precautions. But slowly, I think the larger hospitals will have to start immediately, I think, and the smaller hospitals or the medium-sized hospitals will also have to start, but not necessarily with the precautions that I'm talking about. And we have to find a way. We have to see what happens. Earlier on, I just want to go back to the thought process in terms of numbers. What we don't still have, we need to probably approach the government. See, we're all saying that this is not a true number. Biswarup said that it's probably 5 times, 10 times more than the true number. If the true number is 5 times, 10 times more, then we will have a proportion of patients with really flu-like illness or with respiratory failure coming into the hospital. And the mortality has to have the ratio of around 3% or 1%, whatever it is. And everybody said we don't have the flu-like illnesses coming into hospital. We don't have people being ventilated. But we would like to, what I would like to know from the government is how many patients are they ventilating? And what is the mortality of ventilated patients? Or how many patients are they not ventilating? How many patients are dying without being put into a ventilator? If we have that statistics, how many patients are dying of respiratory failure in hospitals without being ventilated, then we will get a true picture of the number of patients, and we can extrapolate the asymptomatic patients from that number. I think that is the only thing we need. I think perhaps we could ask the government for that data, or IMA can ask the government for that data, or ICMR can provide that data as to the details of mortality is what we need. Not just the COVID diagnosis mortality, but also the mortality of respiratory failure at this time of what's going on, really.
Thank you. May I ask a question to Dr. Biswarup?
Yeah, hi.
You see, the mortality which is reflected, at least in Tamil Nadu, says that 50% of the people who die are below the age of 60.
Okay.
Now, we really do not know what is the mortality in individual age groups.
Yeah.
If we think the elder people should be saved first, but the risk is still there for the people who are under the age of 60. I mean, that is what most people say.
Frankly speaking, a lot of opinions we are making or conclusions we are making based on hearsay. As Prof said, that we do not have stratified data. We do not have classified data. We have a very gross data. These many active cases, these many recovered cases. So until there is classification of the data and then risk stratification, it is impossible to, it will be completely speculation, not even guess. And it will be quite wild guess. So even what I mentioned, that 5 times, 10 times is, I may be right, I may be wrong. It is impossible. So that's why I can't answer your question regarding whether younger people are less risk prone or elder are more risk prone. We are all going by general consensus. And also overall, the science is so unknown. How long the test is valid, how often one should be testing. We are following a policy that in healthcare workers, due to constant exposure, there is no possibility of repeated testing. There is no validity. So we just have to wait for symptoms. So can I?
Mr. One little question before you go to the next subject. I understand in Chennai, 70% of the private sector beds are vacant, 70%.
Yes,
and
that's
they're
what I
not
read.
willing to take any COVID patients, where government hospitals are simply overflowing and no beds. They have taken so many centers all over, and then, I mean, is this what is this dichotomy?
So I think, first of all, what you said is what I read. You're right now in Chennai. You may be knowing the eyeball figure, and after that, when I saw that sting operation yesterday on national channel regarding, I'm sure it's true anywhere. So dichotomy is, if I am running a 350-bed hospital, my primary business is non-COVID. I have to get it back, and this is my postulate. So the only way I can get it back is if I can convey to people that we are a COVID safe hospital. If you come here for knee replacement or XYZ operation, you are unlikely to get COVID because we don't have any COVID patients. The hospitals are catering to future customers' mindset. That is how I would conclude. Why they are saying no hospital is having more than 30% occupancy. No hospital anywhere. In any major cities, yet they are not. Maharashtra is it is taken over already by government. So that answers your question from me. That's my postulate.
Can I answer that?
Yeah, sorry, I forgot.
No. It's you're right. I think the private hospital beds. There are a lot of vacant private hospital beds. The problem is, to convert them into COVID beds is not an easy thing.
Exactly.
For many hospitals, you may only have one common entrance. You may not be able to segregate the wards and departments because they may have a common lift, they'll have a common staircase. So it's actually dangerous to combine. You see, the government hospitals have many blocks. The teaching hospitals have many blocks where they can allocate one block of beds and separate it. And I'm sure Ilango's there, they've got a separate block for COVID, which they can really isolate, but many hospitals are not able to do that. See, when we started, the government said that all private hospitals have to allocate 20% of their beds. That's the rule that they just simply put. But then nothing happened for almost a month. No patient came into a private hospital because there was capacity in the government hospital and nobody was actually referred or no patient wanted to come. And also most of the patients were really not that severe patients. So we simply allocated 20 patients and nothing happened for a long time. And then when patients actually were looking for beds is when we opened up the beds. And we initially had only 20 beds and now we have got 35 patients. And we have a capacity to take probably around 80, 90 patients. Fortunately, our hospital is structured in such a way, we were able to really separate out the COVID patients from non-COVID patients physically. So you can't enter one from one side into the other. But not all private hospitals will be able to separate it out like that. So our COVID section, you cannot enter the general part non-COVID hospital, and from the general hospital, you will not be able to enter the other side. We were fortunate that we were able to structurally change it to do that, but not every private hospital will be able to do that. So therefore, as Biswarup said, our priority is actually to get back the normal activity. And in order to get back normal activity, we have to provide a safe environment for the patients who are coming in, because it is a disaster if they come into hospital and became COVID positive.
Dr.Rela, how will the general public know that, in spite of Rela Hospital being a COVID hospital, that they're safe and they're not going to get into any trouble?
Well, we just have to explain it to them. And if we are not in a position to explain it to them because we are not advertising it, they just have to trust us. And we'll have to reassure them when they are inside that we are completely separate. I think people do trust us, and we have actually regained the normal activity, and we have not had disasters after. I mean, even the first one was not a disaster. The first 4 cases we did not give it to the patients. The patients got it from the community and came into the hospital, because that was proved by testing almost 200 staffs who tested negative.
Yeah, Mr.
So yeah, just the second Dr. Rela, that it is all a matter of perception. We should not feel guilty that if a patient has come to hospital for some operation, this is something we have to believe. Only if we believe, we can make others believe. If a patient has come to our hospital for operation, we can only take precautions. We can't guarantee. So if a patient comes, then becomes positive. So going forward, the main key about regaining, one of the main key, not the only one, is if the people who are stepping into the hospital, if they feel this, giving that feeling that this is a COVID safe hospital in various mechanisms. So to me, later on I'll talk about it, the internal marketing is going to be far more crucial. What they see, what they feel, what they believe is going to be far more crucial to get back and recruit new business than any external marketing, hoarding, or any advertisement. That's what I would conclude with Professor Rela on this.
Yeah, if I can ask you a question here, Mr. See, one of the major concerns now is with most of doctors and paramedical staff is a salary cut.
I'll come to that.
Yeah.
I'll come to that.
Yes.
Before that, I just want to complete, because I'm not an OPD clinician. All of you are. So I just want to talk about a real future of virtual consultation. How are you guys looking at it? I'd like to start with Prof. and then all of you in various locations. Virtual consultation is going to be part of, I can't give a percentage. Maybe follow-ups will become 100% virtual to minimize crowding in the OPD.
Okay, I'll ask Dr. Gautham, my associate, to come in here. Gautham, if you can start with what you feel about virtual consultation, the good and bad of it.
So I think this era will dictate us to switch to virtual consultation. I think it's relatively presumed safe for both the doctor as well as the patient to have an virtual consultation. But I think the rules for virtual consultation is not yet so much developed in India, because I did go through some of the rules. The onus is completely placed on the doctor. The safety of the records, it is, I think, not right on the part of the doctor to call the patient. The patient has to call himself. If there is any issue, then the patient has a right to file a case. It will be in their hometown. Say, for example, if the patient is from Uttar Pradesh and I'm in Tamil Nadu having an teleconsultation, he has a right to file the case at Uttar Pradesh. So I think there are still too many lacunas that are that needs to be set right with respect to the legal aspects of teleconsultation. But yes, once they are plugged, I think we'll have to switch on to that platform to give appropriate care to the wider group of population.
Yeah, I think it is not all is not rosy with teleconsultation, is what I understand. Professor Rela?
Prof, have you started?
Yeah, yes, we do that partially. Let me first, the easiest part is really the follow-up. That can be for the cancer patients, and where it doesn't require really examination, or patients are not going to sue us for not examining the abdomen. For us, it's also, it's all about managing immunosuppressive drugs and their levels, and they can have their blood pressure checked and have their renal function checked. So, and anyway, a lot of transplant programs in the US, a lot of the consultations carried on as a teleconsultation, and now we may have to push all the patients, make them never to come back or go and see their local doctors if they have a problem, and then communicate with us. That's the easy part, and we have already done that. And the other thing that we have done really in the COVID era is in the post-op. We used to have patients coming to hospital twice a week for the blood tests and see a doctor. That's become really, we have a phlebotomist who goes into people wherever they are staying, locally, and then take the blood rather than them coming to hospital. So that's another way we have avoided patients coming into the hospital. I think we should say absolutely no for anybody with an acute illness or a new symptom to have a virtual consultation, teleconsultation. Anybody with a new symptom, anybody with an acute symptom, which they have not had before, you cannot actually manage them through this. You will only get into it. So I think this is only going to be for follow-up patients or new patients who may want to talk to you and see your face and get an idea, and then they have to, and that consultation has to be null and void. It should be not, you should not be legally responsible for any opinion that you give. It may be just a friendly chat, and advise them that they have to come and meet you. That's the only way you can see new patients, really. I don't believe that we can manage patients virtually if they've got acute symptoms or new symptoms, whether it's for cancer or acute illnesses. That's not possible.
I think I'll just conclude that by adding few points which I thought, even though I'm not an OPD or frontline clinician, I think the medical, as Gautham said, the next 6 months we'll see exponential speed in technology as well as medical legality. Because one thing I do believe, what society needs eventually happens. We don't have to make it happen. And technology is going to be, what was going to happen in next 5 years is going to happen in next 5 to 6 months. That is my belief. Second thing is regarding the teleconsultation. Recently, one of our LGS colleagues, Murugan, conducted a poll in LGS. What should be the tariff? Somebody said there are only 3 options: equal, less, or more. And I opted for more because first, the doctor's liability is remaining the same until medical legality is clear. So at the same time, clinical input is suboptimal. So it's a combined difficulty. And thirdly, huge cost involved in the investment in the technology, both operational and archiving. Even follow-up, every consultation is medical legally liable. So considering all these 3 points, the costing has to be worked out, and either it can be absorbed in something else, but it is going to cost. Because I'm getting in Hyderabad, high-tech city, I'm working with a company, IT company, and the technology, good technology for a big volume hospital, it's going to cost. Presently, people are managing with the Microsoft Cloud, but it will not be that friendly, user-friendly going forward. We need a lot more data storage and a lot more intricacies. So that is how I would conclude. But yes, it is going to be consuming at least 40% of our consultation. A follow-up will be 100% virtual.
Baskaran, are you doing the teleconsultation? Unmute.
Very rarely, Radha.
But there's no policy in the hospital?
No, we have a policy. It just that
you're not comfortable.
No, I'm okay with that.
Right.
Yeah. But it's like Dr. Rela said, you can't be using it for anybody with suspected acute conditions. It is okay.
I thought surgeons have a problem with teleconsultation more than anyone else.
Yeah, because we need to examine patients more often than others. Yeah.
Yeah, Biswarup, yeah. Your next topic.
Yeah, so because he wanted to go into, before I go into this topic of, impact on healthcare economics, I'll just mention to all of you what I have understood about healthcare industry. First of all, officially, though it is colloquially called industry, it does not have a legal or official status of industry in this country. Whether it is our fault or government's, because unless we cry, nobody will give. And to me, it has been largely healthcare industry, private healthcare. 80% of India's healthcare is provided by private. And it is very heterogeneous, and I generally call it formally informal. We have formally maintained it in a very informal way. We have associations like IMA, AHPI and all that, but effectively they are teethless. So that is why we right now, when this kind of contingency or emergency struck, and you ask next month's salary, this, that, I'm compelled to make a statement, and I compared with various industries which employ less or even more number of people. The healthcare industry did not possibly have any contingency plan. The employer-employee relation got tested very heavily. In less than 7 days or 10 days. So, because other problem is, in healthcare industry, there are only 3 listed companies. Rest all are private, purely private. So whatever is the P&L or cash flow, cash balance, none of us know. But when it came to crisis, within 7 days or 15 days, we had impact on salaries of employees. Now, for me, this was an eye opener to look at. I always anticipated this by analyzing. It has been an eye opener because no organization maintained a contingency cash balance to look after a situation for 3 months or 4 months at least. This is what my opening statement will be. Further down, I want to discuss something more. Any inputs, please, Prof?
Yeah, and I'll ask straight questions to Professor Rela that, how is he dealing with these employees?
So whether Prof agrees with
has
my
he fired some? I mean, a very frank question. How could he get the heart to fire anyone in the first place?
But before that, Prof, hello?
Yes, I'm listening.
Prof, do you agree with my observations regarding healthcare?
Yeah,
formally, informal?
You're absolutely right. Your observation that the healthcare providers have not made provision for even 3 months in the case of a disaster is a very important question to ask. That means everybody is running it at an edge, really. When everybody thinks that hospitals are making huge amounts of money. But I do believe that there are different kinds of healthcare providers, really. The larger, really, the very large.
Very heterogeneous. It's very heterogeneous.
Yeah, absolutely. The very large group, the international group, which have acquired healthcare, who will have a huge amount of funding. I'm pretty sure it's whether they have the willingness to give that for that 3 months, or whether they think they can get away with it at that time and at this time, and therefore why should they make provisions? Maybe the attitude of some of the providers. I don't believe that none of them have the ability to cope with 3 months of a disaster in the healthcare industry. How have I coped with it? I know that most of you may know that I have a major backer, but I'm not actually. I'm in the healthcare industry. Maybe my business for many people is seen as a highly successful, because the liver program is so large and it moved and it became successful from the first month of us moving in. We did not have to depend on anybody for funding, and in fact, we have been partially subsidizing most of the other departments. If I didn't have to be subsidizing most of the other departments, I can tell you that I would have had funding for not just 3 months, for 6 months to sustain. But that has not been the case. How have I sacked anybody in this month, in this period? I've not sacked a single employee actually. I've not sacked anybody, but maybe 2 people left in this period. And I've looked at so we have made a little bit of saving from really 2 employees, which is not very much. How did people take it? I have actually not had one single person complain to me that they have had to take a cut in their salary. We have looked after the staff at the lower end completely, people who have been paid, the nurses mainly, really under 25,000. This month, all of the nurses, anybody who's really getting paid less than 50,000 is not having any cut in their salary. As a hospital, I think we are probably at a slight disadvantage because all of our consultants are actually employed. So we don't have people, I think we may have 1 or 2 people who may be on a fee for service who work in other institutions, but 95% of our doctors are actually employed, and therefore our salary burden is huge, unlike most hospitals where when they're not doing the case, they're not getting paid. So that would have been a fantastic situation for me, but unfortunately, I believed in a model of full-time employment, and it's a bigger financial burden for me than many other hospitals, really. But we have coped with that. We have had some savings, if all of the people who owe us money give us money back, like the foreign countries and things like that, I tell you, I can even run for another 2-3 months without any difficulty. But money doesn't return back in time, so we have had to have some cuts. But I have to say, not a single doctor came to me and was unhappy, because I think we have looked after them well, and there is a huge trust among the doctors and the other staff in the management we have. We have not had any problem.
I think I will come in here. As I mentioned, now it's a very heterogeneous, and only 3 companies are listed. Rest all financial accounts, nothing is known to public. And also yours happen to be a very personally managed.
That's correct, actually. That's probably why we have never had an issue.
Yeah, so
Biswarup, I'll ask you a layman's question, and you have to answer in layman's terms.
Sure.
Okay. Now, see, Dr.Rela has got a control over all the employees, and they listen. They have an attach. Now, majority hospitals, they have no communication with either the doctor population or the nursing population, and they don't know what is going to happen, why this happened, and there was no
it's very robotic,
communication.
It's very
Isn't
robotic.
that the rule all over?
Yeah, I have worked in few organizations and various parts of the country. When I come across a personalized communication, for me it's a surprise. It's not an expectation. If I find, I call it robotic, dehumanized functioning. Everyone is part of a system. No one is an individual. There are positives and negatives out of it. A very typical, jargon-oriented manager, MBA manager will say that is the way to go. And a doctor manager will think that is not the way to go. Okay, but what you described is by and large the situation.
Now, Dr.Rela, does he give pep talks to all his employees?
I don't
occasionally
think,
saying, we are in difficult times, but we'll save. Because I have not seen any such pep talks, I'll tell you.
I'll tell you before.
But the problem is the pep talks have to be genuine.
Exactly.
Many people who do pep talks for the sake of doing pep talks, and they are very disingenuous. I hate people giving pep talks.
In fact, they are more harmful. Those pep talks are more harmful to the situation.
I am available personally to speak to people, and I have a good management structure where the communication is very smooth. And I believe that we look after people. We look after people at every level. And that is why I believe we have not had a problem so far, and it's unlikely we'll have any problem.
Ilango, your take. Unmute and say.
In my position in the hospital, I think it's way above my decision-making level. So I don't think so. I have a say
You
on
should
that.
have an opinion.
Yes,
Dr. Bapat, you would like to say something, Dr. Jitendra Bapat, in this regard?
Jitendra Bapat has been we studied MD together. He's a consultant anesthetist in Hinduja, Bombay.
Yes, sir. Please come.
Hi. It was a pleasure listening to Professor Rela. I was with you for last masterclass, and Bishu, nice to see you.
Thank you.
I come from West, and as you know, as Dr. Patta and Radha said, we are going to be the epicenter, and numbers speak. So Mumbai and Maharashtra are heading, and that's a worrisome thing for me. I come for a small setup, which is a multi-specialty hospital managed by a small Hinduja Parivar, and they breathe their ethical and moral responsibility. And as Professor rightly said, if there's a communication on one-to-one level in a hospital, such hospitals are not at the fear of losing their employees or so. And I believe into that very much, and I'm a part of it, and I'm on the other side, and I listen to the management speaking to us in these difficult times, and that is going to take a long way. Like Biswarup said, if it's a robotic management, it's going to be a disaster, because if there is no basic understanding in between what is there on paper as an employee-employer relationship, or professionals like us, when we are attached, we are not a salaried people. So no work, no money. It's the same like a person who stays and it's picked up in the Mumbai city to do a daily job. Even a doctor is like the same in private health sector. But if you believe into the system, and if you believe into the nature, how the course is going to be for this pandemic, one has to be a little patient, and one has to be a little understanding that if we survive, then only our managements and our hospitals are going to take care of you. And I think that's the key message what I see, because very recently in Maharashtra, 80% of our beds are captured by government for COVID as well as non-COVID in hospital, and the pricing is capped by GIPSA, and that's a very worrisome thing for the management, I suppose, because to take care of such a big institute, when you are 80% of the beds, if they are governed by GIPSA and they are not going to erode their income, it's going to be a difficult task for managements to really cater to their employees as well. And I really do not know how they are going to cope up with that. But the only thing which will sail through is the ethos what they have to manage their unit as a parivar, or Hinduja Parivar, what they say, and they really mean by that their morals. And I hope that that is going to sustain our hospital in near future.
Can I interfere here? It's interesting because we manage the hospital with all the doctors as salaried, and depending on what money we have, we can actually distribute it to everyone in a proportionate manner. Or depending on if some departments are doing full-time work, we can pay them full-time, and their lower income, we can pay full-time. What happens, you said if there is no work, no pay. Yes. What happens to the doctors who are on a fee-for-service? Like I think a lot of doctors in Apollo, or for instance, fee-for-service. Do they get any money during this period if they are not operating? How does that work?
I'm sure. I'm an anesthetist, but my pay structure in just 2 days later, I'll come to know. But definitely our incomes will be much less as compared to what we had pre-March. And that's fine, because there is no output. If you see the workload in the operation theater, as you rightly mentioned, if you are doing X amount of surgeries, and if you are doing say 1/10, which is basically trauma and malignancy work, because the patients are anxious and trauma can't wait, with all due precautions, your income is going to go down. And obviously all the professionals and the doctors are going to receive a less paycheck this month. That's quite obvious.
So if they've done no work, they get nothing.
Nothing.
Absolutely nothing.
Nothing. Really, if I can ask you, see, not only that the economy suffered as far as doctors' income is concerned, even patients' income has also suffered. But on the contrary, we see the cost of treatment is increased in this COVID era. for whatever reason, the cost of surgery is increased, the cost of the bed charges increase. Don't you agree with it? Is that logical or is it acceptable?
Prof, before you start, just 1 minute. Actually, I will try to give three things are combining simultaneously. We are having increased cost of delivery. On the other side, we are having a combination of decreased volume, hardly any traction there, and decreased paying capacity. So under this situation, please take over. Prof.
Yeah.
So we simplified it.
Yeah, but it's early time now. I still think the public will have a reserve to cope with it, because if you're talking about people who have gone out of job in the lower socioeconomic group, I'm sure the government will look after them. The intermediate group is the problem. When we talk about increasing costs, I think a lot of people are saying there is going to be a huge increase in cost and the PPE is going to cost so much and this and that. In fact, we calculated the increase of cost. The increase of cost is going to be no more than 10% of the cost.
Exactly, 10 to 15% is the max.
Prof, your voice is not clear.
Oh, sorry. I'm saying that the increase in cost is, we did a calculation for the PPE for all procedures. The increase in cost is not going to be more than 10% of the current costs.
Yeah, Baskaran, you want to say something?
Yeah, there are few issues about healthcare industry. As somebody mentioned, I think, it is not organized and it is supposed to be the largest human resources involved in the country. Healthcare is the largest. No, this is what Vice Chairman of Apollo said in I was involved in
the number is correct. Yeah.
As far as the number is concerned, this is unorganized, but it is the largest. The smaller hospitals, which are run by 1 doctor, 2 doctors, 8 doctors, have been hit very badly, especially in Tamil Nadu. The reasons are, one, many of them were scared that in case there is one COVID positive case, not necessarily because of their fault, the hospital is closed. And people were scared to see patients. So now these people apply anything from 8 people to probably 100 people. And many of my friends are running small hospitals like this. So they are dipped into their reserves. They paid their workers. So they said they can pay for a couple of months. Beyond that, they won't be able to pay. So yes, basically, healthcare workers are almost like day care earners, wage earners.
I agree with you. I think it is a real problem. I think for the smaller hospitals, it's going to be a huge problem. Many of the hospitals will struggle now.
Sir, if I can ask one more straight question. There are some hospitals who are dependent on patients coming from one part of the country, and now the transport is hit badly. There are some hospitals who depend on patients coming from overseas. How are they going to cope?
Yeah, so in fact, I was going to frame the same question in a way that is old business model obsolete?
Yeah, how to move forward in this area?
Yeah, I see. Let me talk about my own practice. I think it's a good example. In our practice, probably 40% of our patients are local patients. I'm talking about transplantation, not the other businesses, where most of them are actually, all other departments, we are really catering to the local population. It's Krompet and around really. But when we look at the transplant program, 40% are from Tamil Nadu, of which half may be from Chennai. Around 20 to 30% are from the rest of India, adjacent states really, that have stopped. And almost another 30% of patients for us are from overseas. And that has completely stopped now. So we are expecting that if we look at the annual revenue for us for the whole year, we are going to have at least a 40% drop in the overall business. That means we have got a huge number of staff and a salary that we may not be able to afford for the rest of the year.
Yes, so I was going to, what I have thought of, I will share with you, Prof. Probably the places have to, hospitals will have to restructure their portfolio the more diversified the portfolio, better is the, I know it's not going to be easy, and less dependent on one segment, more diversified. It's like stock market. That's number one. And number two, this period will possibly the period where relation between the hospital and surrounding 5 to 10 kilometer neighborhood, that is going to be the test and the connection. For me, that is why the old business model will not be valid anymore in most places. Do you agree?
I agree. I agree with you entirely. From the day I started in our hospital, I've always said we need to focus on the local population to provide the best of the service and provide the service at a cost-effective manner, the local population. And when you win over your local people, you will be successful come what may. None of the disasters are going to affect you. Most of the corporate hospitals that I visit, people I visit, in the last 5 years have always been talking about how do I attract international patients? How do I get international patients? I think that's going to be obsolete, actually. I think international patients will come. I'm not saying they will not come, because particularly for higher specialty like us, not every country will be able to really start a transplant program. We are talking about countries with 2 million, 3 million population. Transplant programs, liver transplant programs, or heart transplant programs not going to be viable. They will come. But I think I have again and again repeatedly told people, wherever I go and talk to them, everybody says, oh, we want to attract international patients. How are you managing to do? Have you got agents here? Have you got agents there? I said, that's a wrong way to run a business. You have to win over your local population, and that is their strength. And if you actually can look after local population and they trust you and come to you, your business become really unshakable. And you're absolutely right. And that's the direction with which we have to be moving.
I think that's one point. And I'll just go back to a few years ago, before joining a hospital in Hyderabad, I asked the CEO, I didn't ask about total revenue. All I asked is the portfolio distribution. And the CEO said 65% of his revenue comes from cardiac sciences. And I said, and you were still sitting and you are not distributing the portfolio. And eventually some stent price control happened, and overnight, it doesn't have to be natural disaster. It can be a government policy change or something. And within a matter of months, 40% of his projected revenue disappeared. So my another take is that anyone who wants to run a composite 350-bed hospital has to actively diversify the portfolio over next 6 months to 1 year to minimize the next March closer deficit to minimum. That's what my take.
Biswarup, we've been already 1.5 hours into the meeting.
Sure.
And we've taken much time from Dr.Rela. I'll open the floor for questions the last few minutes. Anyone wants to comment, ask Dr.Rela, Dr. Biswarup? We can start with Amaravani. Are you still, I can see a hand raised. Do you have anything to ask?
Am I audible?
Yes.
Yes.
Just wanted to comment one thing about this online consultations. I think it is still in the infancy in India. In foreign countries like in USA, people are still doing, because the most of the chronic patients are coming for the refills. So it is easier for them to do that online. For acute patients and patients with COVID symptoms, they are telling them to go to the hospitals. They are not allowing even to come to the clinic or even for the online consultations.
May I comment on this? Very recently, Telemedicine Society of India has done a lot of work on it, and actually the all protocols has been laid down, and they have seen that there is a complete immunity from medical legal suing. So I think the fear of being taken to the court just because you are doing telemedicine or tele consultation is going to go down. And Telemedicine Society of India is doing a really great job. Very recently, their all protocols and everything has been passed by the government of India. And I don't think we should fear that much in that area.
Ilango?
Sir, I have a couple of questions. One is how is the supply chain now? We find a lot of local PPEs which are not meeting our quality requirements, and we are unable to get good quality stuff on N95 masks. And is that going to be disrupted? It feels like it is going to be disrupted for quite some time because of international trade restrictions which can come in. Should we improve the supply chain to local places where? So if so, what we should be doing? I would like to hear both of your thoughts on this.
Viswarup, I have to say I've not been informed that there is a problem with PPE, and we have always gone for high quality stuff. Really, I cannot answer that question. We have had no problem. Maybe in the early stages there have been problem with PPEs and an N95 mask, but currently I think we have good quality PPE and good quality N95 mask. Viswarup, is that a problem?
April there was. In the month of April there was.
Yeah, in the early stages there was. Currently, I don't think there is an issue.
We are not facing that problem. And I think going forward, it's going to be
do we have quality Indian-made
Yeah, see, we are getting currently, we got a supply set from 3M N95 masks. But the numbers are still less.
3M is not Indian.
3M is not Indian. So we were lucky to have that. The local ones, which we get from Venus, they still have a lot of leaks. And even the quality of the Magnum duck-billed ones, which are the ones which we found fits our nurses. They have smaller chins. So those are not of good quality. And we feel we are unnecessarily exposing them to a higher risk in a very risky environment where there's a chance that they may lose their life. So we want to be very, very careful for it. So we keep checking the quality of the individual PPE batches, and we still find a lot of difficulties. The initial set of coveralls which we got, we tested on ourselves and found that they were completely, they were not fitting us properly, both the doctors as well as nurses. Either the size was too big, the mobility was extremely restrictive, and it is very difficult to wear them for a longer time. So we have also now we are getting DuPont Tyvek and stuff like that. But is that because of the extreme demand all over the world? Do you think those supply chain problems will be there in the immediate future? And should we improve industrial infrastructure locally so that we get good quality stuff? For surgery, we have actually talked with the local manufacturers, and we gave some specifications, and they are coming up with newer models every time so that our surgery becomes easier even when we do on COVID positive patients. So I want to know whether you have thought on those lines and your opinion on that.
I don't think there is a problem with availability currently. I think they have been manufacturing quite a lot in China, and I think the distribution has been okay. It is right in saying that we need to actually, there is going to be a huge change. That's what the Prime Minister is saying as well, that most of the products will have to be made locally for the future. So when at times of disasters, there is no problem in trying to import stuff. But I still have my doubts that we can keep up those principles and start. We still have a huge problem with quality control in this country. There has to be a rapid change in the way that we have quality control here. I don't.
Any other question from the audience? Now, actually, on a lighter note, Dr.Rela has got multiple interests, and one of the interests is Kamaramayana. I just want to know as to what is your new interest. I think you must have done with Kamaramayana already, since you had so much free time. What are the newer interests you got into?
I actually, in the beginning, I was actually doing a lot of Kamaramayana. I've been asked by the Kamban Karaham to actually give them a lecture by the end of next week, actually. So I'm really preparing for one of that. The second thing I really did was I started exercising a lot, and I've lost about 6 kilograms in weight. So I did not do that for many, many years. I think I've lost more weight than I've ever tried to do before. So that's been also a very useful thing. And the last thing I said before was I really took the opportunity to rest the first 2 weeks. Slept a lot, and for some reason, everything was out of my mind. I did not worry about most things at that time. There was no work to do. There was no transplants to do. There was no question and answers from patients. I just slept and slept and slept, and then had a huge amount of work done on Kambaramayam. And then finally, I went into exercising. So those 3 things that I did in this.
So what is the next thing after Kambaramayam?
Oh, there is plenty to do there. I've got still 1 or 2 years that I can learn more, actually. I think it's better to stick to one. I have an interest in Bhardiyar, and maybe I'll take on Bhardiyar's work next.
Sir,
yeah, Ilango.
I still have some questions on the prime topic.
Yes.
Prof, we found out, we have some difficulty with regard to the use of paper case sheets. And I'm always concerned when the patient comes back from the COVID ward, even though they are tested negative, the case sheets being handled by the nurses, we still consider this as a fomite. They come in a covered package, but is this good time for us to introduce EMR? We have a basic EMR in our hospital, which we are trying to use, but most of the use is actually very minimal. Is this the right time to push towards EMR in all the hospitals?
I think that's a very good point, actually. But when patients get discharged from the COVID ward, I think the notes go to a place where they are left alone without being touched for about 4 days. And then only they go to a separate section in our hospital, where again they are stored. So they don't get touched for about 4 days, and then only they moved. But you're right, absolutely. I think most of the countries are going to electronic medical records, and this is probably a good time to push that. But we've all been so used to actually looking at our own handwriting. Instantly when you see
one question.
Yeah.
Awesome. What are the things you would like to suggest to reboot the healthcare sector, apart from government's initiative, which is very unlikely to come, because they got far too many things to do. So from individual level, what all we can do to kickstart healthcare industry?
I just described how we actually kickstarted. Actually, we have sent off a paper to Annals of Surgery very ambitiously. I don't know if it will get accepted, as to really how we restarted. I think we just have to have the courage to restart and take precautions. And I said earlier, treat every patient like COVID patients, but it doesn't have to be 100% COVID PPE. Test all the patients who come into your service before you start. And also a lot of it depends on the region where you practice. I think Chenna is a hotspot, and we need to understand where patients come from, what the risks are in that area. If people are practicing in smaller towns and cities where it's not a huge problem, I don't think they should worry too much. And everything will depend on when you test and what you see. And if none of your patients are positive, if you're testing the first 50 patients, then I think you should relax the way you are being spending money on patients. I think people have to restart. I've been in many doctors group where they're advising their colleagues to say, oh, shut your clinic and don't do that, don't do this. I don't think the government is currently having the same attitude as they did in the early days, where they're being very, where they're shutting down hospital. That's not been the policy anymore. And therefore, I think we need to protect ourselves. I have to say to everyone that you need to protect yourselves, but restart and see how things work. It's no big
On that note, Biswarup, I think we had a wonderful discussion, and actually it's very encouraging to hear from Professor Rela that you restart, get back to what you were earlier, and don't hesitate, and take all the adequate care and have good protection, and keep going and don't hesitate. And then of course other things is that you should all still work as a team. The hospital administrators should understand that they have to keep their flock together and keep them in good books and not to fire anyone. Then also should focus on local population. And I think there's so many nice points we have got from our conversation. And one final word by Biswarup and Dr. Rela, then we'll close.
Prof, you go first, please.
No, I mean, the message is the same. I think everybody is going to have their own experience when they restart. They will have problems when they restart, but that should not put them off from continuing to work. As long as they keep themselves and the staff. And as you said, if a patient becomes positive, it's not their fault. We did not manufacture the virus.
Exactly. We should not feel guilty.
We have to get on with what we have been doing before. And we will learn when we restart, we will learn what the issues are, and we will change as things crop up. And finally, we need to get back to what we were doing. And that's what the patients need ultimately, because there are many non-COVID patients suffering now. Actually, the deaths from non-COVID is going to be much more than the deaths from COVID in our country.
Absolutely. So, I mean, to close, I would just say, because Baskaran was saying, I think there is no question of getting a help from government, because healthcare is the private at all times. Private healthcare especially is a favorite weeping boy for governments, anywhere, state governments. Time in Chennai, Punamalli High Road, I used to practice in 10 nursing homes from morning 5 to evening 8. My heart goes out, because going forward in next 6 to 8 months, such MSMEs really do not have. If 10-year-old, 15-year-old MNC hospital corporates could not sustain for 3 months, then let's not expect them. So from that count, I think it is very important as seniors, wherever we are, we must encourage people to come back to work. By staying away from work, whether we get disease or not, we will also become redundant. Thank you, Prof, for accepting my invitation.
Thank you very much.
Thank you, Professor Rela. It's wonderful speaking to you. Thanks, everyone. Thanks, Biswarup. And I think we shall meet sometime soon. And I would request Professor Rela to talk to us about the topic closer to his heart, the liver-related issues.
I can do that. I can do HPB and liver. Yeah.
Sure, sir. Thank you so much. Thanks, everyone. Good
Bye,
night.
everyone.
Have a nice Sunday. Thanks. Thank you.
It was pleasure, Professor Rela and Biswarup, to listen to you. Thank you for inviting.
Thanks, everyone.